we are seeing one more ABG. And the first thing to see in ABG is this pH. So in this pH, pH is 7.16. What is the normal range of pH? It's from 7.35 to 7.45. So less than 7.35 is acidemia, and more than 7.45 is alkalemia. So the one more important thing that we need to understand is this acidemia is extremely toxic. If the pH is less than 7.35, lesser is the value, bad could be the outcome, because acidemia, it reduces the inotropic activity of the heart. It means it is very, very difficult for the heart to maintain the blood pressure. Second thing, this acidemia begets acidemia, because in acidemia there is peripheral vasodilation, so that the blood can be given more to the tissues. And to compensate this peripheral vasodilation and to maintain the blood pressure, there is again systemic vasoconstriction as well. So there is basically a tug of war between vasoconstriction and vasodilation. And usually the vasoconstriction wins, and the peripheral vasodilation is kind of lesser, so that the peripheral tissues like muscles, nerves, bones, gut, they reduce lesser blood supply, and all this blood is transferred more of a shuttle to heart, brain, kidneys, liver, to maintain the core functions of the body. So it's very important to come to know that this vasoconstriction, vasodilation, reduce inotropic activity of heart. These are all very much common problems of this acidemia. Now, the one more thing is, okay, this acidemia significantly can increase the risk of arrhythmias. So, patient has very high risk of VT, VFib, or asystole, especially if the patient has, first thing is hypertension, and the second thing, uh, electrolyte imbalance in the form of hyperkalemia or hypokalemia. So if the potassium level, if it is more than 6 milli equivalent per liter, or if it is less than 3.5 milli equivalent per liter, that can also significantly, markedly increase the risk of asystole or arrhythmias. So it's very, very important to know all these things. Now, what other things we need to see in this acidemia is, what is the primary cause, whether it is metabolic acidemia or respiratory acidemia. So what is the cause, whether it is lung related or metabolic related. And how can we come to know is, what we need to simply see is this PCO2 versus sodium bicarbonate, sorry, the bicarbonate. So if we can see, this sodium bicarbonate standard is 10.6. So what is the normal range of bicarbonate is from 22 to 26, and the range of PCO2 is between 35 to 45. So whenever there is CO2 retention, means whenever PCO2 will be more than 45, or whenever bicarbonate is less than 22, these things will cause acidemia. So in this scenario, acidemia is there because pH is lesser. So this bicarb is less. So as per this thing, we know that this is fitting and this is not. So this is primarily metabolic acidemia. And the thing is, this PCO2 is lesser. It means that patient's RR is high. What is PCO2? PCO2 is, in short, the concentration or amount of the, it is the partial pressure of carbon dioxide in the blood. So it has to be less, it has to be in between 35 to 45. But in this case, the PCO2 is lesser, means the patient is simply tachypneic. The respiratory rate of the patient is high. That is the reason why the CO2 is getting washed off, means the patient is tachypneic, and that is one of the compensatory, one of the most important compensatory mechanism to tackle the metabolic acidemia. If we calculate, whenever there is one simple calculation for this, whenever the patient has metabolic acidemia, depending on the level of bicarbonate, we can come to know what should be the actual PCO2 level. There is one formula for that, and the formula is we need to see the bicarbonate, we have to multiply it by 1.5 and we have to add 8. So in this case, the standard is around 10.6. So 1.5 times 10.5 or 10 is 15. So 15 plus 8 should be around 23. So in this case, it is around 25. So it is more of a trying to compensate the thing, but acidemia is there and that is significant. The other things we need to say is, as I said, the acidemia has hypotension. The acidemia has very much a risk of arrhythmias. So what we need to see is we need to see this lactate. So normally the level of lactate has to be less than 2. So if it is more than 2, it means the patient is dehydrated. So in that scenario, to tackle this dehydration and hypotension, we can give IV fluids. So this IV fluids can borrow us some time to tackle the dehydration as well as hypotension, so that the patient won't die for few hours or few minutes, and we can fix up the underlying problem. So it's very important to know what is the lactate level. If the lactate is more than 2, it means ki we may have a scope for giving IV fluids, which can borrow some time to prevent the hypertension. So fluids which are commonly given is NS or RL. It can be given like 400 to 500 ml NS bolus, and we can again continue the IV fluids at 100 to 120 ml per hour. At least for a few hours, we need to again repeat the ABG after an hour or two, because we need to definitely make sure that this ABG is getting better and better. So we have seen pH, PCO2, lactate. We need to see glucose. What is the level of glucose? If it is we call it as hypoglycemia. If it is less than 70 milligram per deciliter, the patient should be having a BSL of at least more than 80, but it should not be more than like 250 or 300. Otherwise, it can be a DKA as well. If the patient sugar is more than 300 and the patient has acidemia, you should always suspect of diabetes ketoacidosis. So sugar has to be seen definitely. And this bicarbonate is very important. This base excess is one parameter. If it is less than -2, means if it is -4, -8, -10, like in this case -18, it suggests acidemia. And if it is more than +2, like +5, +6, it suggests alkalemia. So this is all about today's class. We'll be again seeing in next class.